All right, I guess in the interest of time, I'm going to go ahead and get started. Looks like we have a bit of a quorum already. For those of you who don't know me, my name is Eric Yang. I'm one of the cardiac MRI faculty. And you've probably heard this talk last year, and there's been probably a few minor updates, but for the most part, it's about the same. But what I'm going to talk to you guys today is about stress MRI and go over its current role and go over some case studies. So this is going to be a live audience interaction, so please bear with me. The CMR fellows have already been forewarned. So I'm going to start off with the most basic of principles and ask you guys, why do stress testing? Why do we even stress patients? Can you guys think of some reasons? And cardiology fellows, you guys are going to be picked on. Brian?
Patient has chest pain or something, you're looking for evidence of ischemia.
So ischemia evaluation, that's one good reason. Any other reasons?
Prognosis, functional capacity.
Yes. Anything else, Basil?
For CMR specifically or just
in general, yes. Chronotropic competence is, yes, that's something unique to exercise testing and all, but yes, you're right, Nadine. Anything else?
Valvular disease as well as
I heard from Shad in viability assessment, so confirming whether or not there's hemodynamic consequence of a coronary lesion. And so, very good. You guys pretty much picked up most of this stuff. And all of you should be pretty familiar on the area of CAD detection, the Diamond-Forster classification of different forms of angina. So this is work looking at the different probabilities of whether or not a patient has CAD based on symptoms. And when I'm talking about CAD here, this is confirmed angiographic greater than 50% stenosis on a coronary angiogram. And this is just asking three simple questions. Just if the pain is occurring in the chest, if this occurs with a provocation, usually stress or usually exercise stress or emotional stress, and if this is alleviated with rest or nitroglycerin. And this is just a basic premise of how to classify the patients in terms of probability of CAD. Obviously, if the patient's low risk, there's no point in really doing much testing other than maybe a treadmill and leaving it at that. If they're high risk, there's no reason to do any further stress testing. These patients usually go straight for coronary angiogram to find the culprit lesion and plan any further interventions. It's the patients who fall into the big intermediate category, the big gray area, that stress testing then has a big role in trying to further risk stratify these patients and then determine if intervention is potentially necessary. So in terms of how patients respond to flow-limiting lesion, this gets into what we call the ischemia cascade. So by the time patients show up with chest pain, their lesion's already pretty far advanced, and that can be seen on this graph here. Once the flow-limiting consequences have manifested and the patient's already developing symptoms. The idea of trying to do stress testing and doing the different techniques we have is to try to pick it up much earlier, because as you can see, there are different stages. Once flow-limiting lesions set in, that different manifestations such as perfusion abnormalities, metabolic alterations, diastolic dysfunction, regional wall motion abnormalities, and systolic dysfunction, ECG changes, and finally symptoms set in. CMR is actually able to look at different parts of this, as you can see, and they're marked here in terms of perfusion for abnormalities, cine for wall motion abnormalities, and delayed enhancements once a full-blown myocardial infarction is manifest. Okay. So how do we stress patients? Some of you alluded to doing stuff with like exercise, so we can do treadmills, we can do recumbent bikes, and then of course we have the plethora of what we call pharmacologic or chemical stress testing. And with these we have many agents that have been widely used and studied in various settings. Dobutamine in the stress echo realm, that's everyone's pretty familiar with that. Then we have vasodilator stress agents like dipyridamole, adenosine, and more recently regadenoson as well. Okay. So in terms of the hemodynamics of coronary stenosis, this is a nice graph just showing what happens as you get various grades of stenosis. And shown here, for example, is what happens when you start off with a 50% lesion versus a more significant 70% and 90% in terms of what happens to the pressure drop with a given increase in flow. With vasodilation, you again see how much flow gets limited as stenosis increases on this graph here. And same thing here. What happens with vasodilatation of stenosis resistance compared to baseline? Okay. And this is the kind of the concept of what happens when we're doing vasodilator stress. When we start off with rest, everyone starts off with a standard amount of blood flow going through the different coronary vessels. Shown here is 1 milliliters per grams per minute of myocardium. And this is true for even significant stenoses of 70% and 90%. And once we apply vasodilator, we then increase the overall demand overall coronary dilatory response and increase the amount of coronary blood flow. In a patient who has stenosis, the amount of blood flow that then is able to pass through is limited, so we didn't get a relative perfusion decrease shown in these two bottom cases here. I hope that makes sense, because that's the premise of looking for regional differences in coronary blood perfusion, hence regional wall differences with different stress tests like myocardial perfusion imaging in nuclear and CMR. Okay. In terms of how they compare in detecting significant CAD, shown here is the different modalities and stress combinations you can do. Exercise ECG, unfortunately, is very poor at it, shown here at having sensitivities in the 60s and 70s and specificity. Echo improves it to some degree, and so does SPECT. And pharmacologic stress testing improves it further, as you can see here, to the 80s and 90s. So now that I covered the basics of stress, I'd like to move on to why you all are here for this talk, whether or not stress testing can be done with CMR. So what kind of stuff do we need to do stress testing with CMR? Obviously, we need a magnet, so we need scanners that are capable of allowing us to acquire MRIs. And of course, we need gadolinium, because then this lets us do perfusion imaging and see the amount of blood flow going, relative blood flow going through the different walls. And not just any MRI can accomplish this. This has to be a cardiac MRI capable scanner. So these are scanners that have to be able to track the patient's rhythm, because you need to gate it and compensate for the cardiac motion. And hence, we have ECG systems that are electrode systems that are compatible with the MRI. You can't just put any electrode in, and one of our CMR fellows has discovered this one weekend with his volunteer. You have to have a contrast injection system that can deliver the contrast at a fast enough bolus to see the contrast going through the different parts of the heart, along with, of course, an IV stand for delivering medications as well. You need an intercom system, of course, to be able to communicate with the patients and give them instructions to breath hold, because unfortunately, with cardiac MRI, we need the patient's diaphragm to hold relatively still. Otherwise, if the patient breathes all over the place, then that makes image acquisition difficult. Of course, when you're doing all this, you want to be able to monitor the patient closely, and so you need MRI-safe, compatible telemetry systems. So we have those that then relay the information wirelessly and allow us to watch the ECG rhythm, watch the O2 stat, and watch all those other parameters. And of course, the most important of these components is the CMR staff. You need fellows and attendings who are capable of looking out for different complications, nurses to help administer the medications, place the IVs, and help monitor the patient. And I can't say enough about the technologists here. The technologists know very well to scan set up the scan sequences, compensate for the cardiac rhythm, and adjust parameters as necessary. And so very well-trained staff are extremely helpful. Okay. In terms of what cardiac MRI can offer compared to other imaging modalities, well, the nice thing about cardiac MRI is that we don't have a limitation in terms of body habitus or lung disease. Well, semi-true. If the patient's too wide for the magnet bore, then we can't get them in there. But overall, that so long as they can fit inside the bore of the magnet, that doesn't stop us from performing a CMR scan. The nice thing about MRI too is, unlike other modalities, other than echo, we don't use radiation. We don't use iodine contrast. We use a gadolinium contrast. That being said, we do still have a limitation with kidney function because of the extremely rare risk of nephrogenic systemic fibrosis in patients with GFR less than 30. The nice thing is that we're able to obtain identical positions in the body in terms of our imaging. So we can set any scan plane we want and go back and repeat that imaging scan plane. So we can do that for looking at CNAs, looking at perfusion, looking at delayed enhancement as well. And of course, as I just mentioned, we can do direct scar assessment looking at the same location we just looked at with CNAs on our MRIs. As I mentioned, not everyone is a great candidate for a cardiac MRI, so if the patient's too wide for the magnet, then they can't get a cardiac MRI. They won't be able to fit into the magnet, and unfortunately, we can't change the laws of physics and space. If they're claustrophobic, obviously they wouldn't be a good candidate because it is a pretty confined area. I'm talking about a 60 centimeter bore for the 1.5 Tesla magnets and a 70 centimeter diameter bore for our 3 Tesla. Again, the patients have to be able to ideally should be able to do breath holds. If they can't do breath holds, then the images are going to go all over the place and reduce our image qualities. So unfortunately, patients who are huffing and puffing and like decompensated heart failure patients, probably not the best patient to be sending down for a cardiac MRI in general. And of course, I did mention that we do have a very rare risk of nephrogenic systemic fibrosis, more with renal patients. But we also use a fairly new generation contrast agent that seems to have much less risk of that, but the jury's still out there on that. Okay. Now, can we do exercise stress testing? Turns out you can. There's at least one group in the US that's looked at treadmill, and they have this entire elaborate system where they have an MRI safe treadmill machine right next to the magnet. They'll actually scan the patient, inflate this system that you can see here that actually remembers the imprint of the patient's body. So once they get the patient after the initial scan, they'll then run them on the treadmill, put them back into this body mold so they can get kind of the relative same position, hit the button, and have everything ready to go. Kind of a little involved, so not exactly being adopted readily by most institutions, but just so you're aware, it's out there. We also have recumbent bike, and believe it or not, at one point our heart failure group was looking at this with us. There was the idea of doing dynamic cardiac assessment on patients at different bike workloads. I believe this is still being talked about a bit, but I haven't heard much in terms of bringing a bike to Methodist yet. How does CMR by exercise compare to SPECT? It's actually pretty comparable. Then again, this isn't our center, so who knows how SPECT here would compare to exercise CMR. But as you can see, in terms of sensitivity, CMR performs a little bit better compared to SPECT. Okay. At least in this one study. How about looking at the coronaries directly? We can, and we do on occasion. Sometimes we're asked to look at congenital. There are some data out there for looking at the more distal vessels for coronary MRI. Unfortunately, in terms of spatial resolution, we really can't compete with cardiac CT. Our spatial resolution is somewhere between the order of 1 to 2 millimeters, whereas the spatial resolution of cardiac CT can actually go below a millimeter. So if I had a choice between picking cardiac CT versus coronary CMR, I would rather pick cardiac CT instead. Okay. This is this was a study done recently showing the sensitivity and specificity of detecting CAD lesions by coronary MRI. And here the data look pretty good, but then again, if you have good data and you publish it, then you tend to have a little publication bias with that. And of course, another reason we often get patients referred to us for cardiac MRI, for coronary MRA, I should say, is looking for congenital anomalies. We still can do it. We do it a lot in our congenital population, and of course, sometimes patients are sent for this. But again, if I had a choice, being able to look at the more distal vessels, I would prefer cardiac CT over CMR for this. Okay. Moving along, talking about stress cardiac MRI itself. We can actually do Dobutamine CMR. In fact, we used to do this a lot more when we were assessing questionable aortic stenosis, whether or not it was pseudo-stenosis and all. And there's actually pretty good data out there. There are at least quite a few studies that I'll show in a meta-analysis looking at this. But what we basically do is we start off with our basic cine that you can see here, give them dobutamine and at different stages, same thing as echo, and then at the very end give them contrast and do the rest of it with recovery and late gadolinium enhancement. Okay. The difficulty though is that, as you know, dobutamine is a beta agonist, stimulates the heart rate, accelerates that, and when the heart rates get really fast in cardiac MRI, that makes it harder to track the heart. So just like cardiac CT has issues with gating coronaries when the heart rate's too fast, CMR has a little difficulty tracking things when things go too fast, although we can do that. Okay? So what I'd like to do is show you a case of a 60-year-old male who had effort-induced chest pain for about 4 weeks, and past medical history is significant for degenerative heart disease. Let's see if this will pull up. Okay, so shown at the very top are cines of the patient at rest, and not much in terms of wall motion that you can see here, right? Okay. Shown here is dobutamine being given at 10 micrograms. And you can see there's a little more augmentation in terms of contractility. And what do you guys think? Still not pretty good augmentation, right? So, but not much in terms of wall motion abnormalities. Here it is at 20. And finally at 40. And what do you notice? The lateral walls begin to look a little sluggish, huh? And this is a little more evident on the apical floor. Okay. And shown down below here is the delayed enhancement. And what do you guys see on the delayed enhancement? Yes, so there's an infarct in the subendocardial infarct in the lateral wall. So this patient clearly has CAD, and now is evident, although we picked that up on the dobutamine without contrast. Okay. This is an example of a patient that's being evaluated for CAD using dobutamine. And like I said, there's been quite a bit of data using Dobutamine CMR over the years. And you can see there are quite a lot of trials that were done establishing its reproducibility, reliability, and comparing it to different other modalities, all the way from 1992 to more recently. And in terms of studies, there were actually about 37 studies done using stress CMR, about a third of which, 14 really, that looked at dobutamine. And as you can see, dobutamine does have a pretty good sensitivity and specificity overall. I believe it's in the bottom data down here below. The top is vasodilator stress. The remaining 20 20 plus or so. Okay. So that's all nice and fine. Of course, like I said, there are difficulties with using dobutamine in the cardiac MRI lab, not least of which is if the heart rate gets too fast and it gets a little difficult to get the scanner to track the heart and get enough cardiac phases to see what's going on. So why not instead try to do perfusion, give contrast similar to what's done in the nuclear world, and see how the myocardium lights up. And one of the questions that was asked was whether or not we can see perfusion differences detectable on CMR. So how do we do it? What we do is we infuse contrast rapidly, and we can actually see it as it transitions through the different blood pools. So shown here is before contrast, as contrast is transiting through the RV, through the pulmonary circulation, back through the LV, and then through the coronaries, through the myocardium. And as you can see, the myocardium actually does light up and eventually washes out. And we can actually see that first the blood pool enhances first. This is signal intensity as the contrast is going through its different phases, and then myocardium as it lights up and picks up contrast. The principle behind this is that the Galilean contrast shortens T1 and does increase signal intensity on T1 weighted images. Okay. This is just showing it in real time. Let's see if this plays. And again, you see RV lights up, LV lights up, and what do you notice on this image? Yes, you actually see this entire region here, the anterior and the anterior septal appear dark relative to the remainder of the myocardium. So this patient likely has an LAD lesion of some sort, but this is just demonstrating the principle of contrast perfusion. But the nice thing you'll be able to see is that we can appreciate not only what wall segments are involved, but we can also see the thickness, the extent of thickness of the myocardium that's compromised by whatever ischemia is going on. Okay. So in terms of whether or not there's any limits in terms of detection, work done by my alma mater, Northwestern, showed that if you had a twofold difference, you can consistently see this on visually without needing to use more sophisticated computer algorithms to process this. Although ideally one would be able to do more quantitative measurements, that's been mostly in the research realm. Most of this stuff is done semi-quantitatively, where we use visual estimate of extent. Okay. This is just showing more studies from Northwestern, where they compared it to microsphere perfusion as well, and compared it to thallium as well. And as you can see, there's pretty good agreement between the different comparisons here. Okay. So what are differences between CMR and SPECT? CMR, we can actually look at the contrast as it's transiting through the different vascular structures and through the myocardium. So we can actually see the perfusion as it's going. We can see the kinetics, if you will. We can actually see it at a spatial resolution of about 3 by 3 millimeters and 8 millimeters thickness. And we're getting dynamic images. So we're actually, like I said, like I showed you, getting an actual cine clip as the contrast is passing through. This is unlike SPECT, where when we give perfusion, we have to wait a couple hours for the contrast, for the nuclear tracer to be taken up by the mitochondria of the myocytes. The spatial resolution, unfortunately, is quite a bit inferior. We're talking about 10 millimeter by 10 millimeter spatial resolution. And when you look at the number of cardiac cycles you can get over this, it's usually only 8 frames per cardiac cycle. Hopefully, though, now that Dr. Moaz has joined us, we can get our PET systems up and running and get a better resolution on the nuclear side. Okay. Other studies have been done that have also established its comparability between CMR and SPECT in terms of detecting coronary disease. The MR Impact study, for example, actually looked at CMR versus SPECT head-to-head. And what did they find? They actually found that CMR and SPECT were roughly comparable in terms of sensitivity and specificity, with maybe a little advantage to CMR. when pooled, when the results were pooled. When looking at differences between readers, they actually found that that improved to some degree as well. There's an even larger registry that published in 2013 in about 27,000 patients. And this was answering a different question, not sensitivity and specificity between modalities, but asking if CMR actually changed the management decision in these patients. And what they found was that, yes, indeed it did. In the 27,000 patients that recruited and included in the study, they found 9% had a different diagnosis than anticipated. It actually led to a change in medication for 25% and invasive procedure in 17%, and actually changed hospital management in a fair percentage of patients as well. So yes, ordering a CMR does impact the decision making in these patients. Okay. This was presented back in ACC 2017, and this was actually answering yet a different question, because one of the big questions that come up is whether or not an intermediate lesion actually has any kind of hemodynamic consequence. And currently, our gold standard is doing invasive fractional flow reserve, FFR, in the cath lab. So this group in the UK actually decided to recruit about 900 patients, randomize them between FFR-informed, where every patient got an angiogram and got FFR, versus MR-informed decision-making. And what they found and released in the ACC 2017 presentation was that MR-informed led to less invasive testing and was roughly comparable otherwise in terms of outcomes for FFR versus MR. So how do we do vasodilator CMR? This is a protocol showing the basic idea. Start off again with a cine and getting a cine and morphology information. We usually do it in reverse compared to what you would expect in nuclear. We start off with stress, get additional imaging, get rest, and then get delayed enhancements. I know nuclear has an accelerated protocol where they actually get stress first, and then if there's any abnormality, then bring the patient back. But in this case, we actually get the rest images for reasons I'll explain very shortly. Okay. So I showed you what CMR is capable of. We can get cine information. We can get wall motion abnormality information on the heart in these patients. We can actually get stress data and rest data on these patients as well. And we can also get delayed enhancement showing whether or not there's been prior infarct in these patients. In terms of how we combine these data and figure out a systematic approach to interpreting this, as you can see, there's quite a large number of permutations. You can actually do 16 different combinations. So what's the best approach? How should this be handled? And turns out the group at Duke, when Dr. Shah was working with them, actually went ahead and tried to answer this question. And what they asked was, what algorithm would best allow us to detect CAD by CMR? So this is different between answering, is there ischemia? This is just simply detecting whether or not there's CAD, yes or no. So they came up with this algorithm. Instead of going straight to the stress and rest perfusions, they actually start off with looking at the delayed enhancement. If you have delayed enhancement present, you clearly have evidence of prior MI. That's evidence that this patient's had a prior infarct and therefore has CAD present. So you're done at this stage. You've answered the question, the patient has CAD. Okay. If it's negative, then you go on to the next stage, and if you see an abnormality, if you see no abnormality, then you're done. This patient has no CAD. That's the end of that algorithm. But if you do have a positive defect, a perfusion abnormality on the stress that's suggestive of possible CAD, then you look at the rest. And the reason why we need the rest perfusion in this case is because if it turns out that you have a defect that goes away on rest, just like with nuclear, a quote-unquote reversible defect counts as definite ischemia. Whereas if you have a quote match defect, in nuclear we interpret that as infarct, right? But we already answered that question with delayed enhancement. Delayed enhancement shows us infarct. So in this case, the only other thing it could be is an MRI artifact. I want to make that point very clear. A match defect between stress and rest on CMR is not infarct, it's an artifact. Okay. There is one caveat though. If we do image too soon, the rest after stress, you could have a little persistent ischemia, persistent defect. And so that can mislead you into thinking that's artifact. Does that make sense? Because normally you have to wait a certain amount of period for the coronaries to recover and go back to normal. But if you do it too soon after, and I'm talking like within 5 minutes, you can get an MRI.
What do you deal with non-stop endocardial?
I beg your pardon, Dr. Chang?
How do you deal with non-stop endocardial enhancement?
So the question is, how do we deal with non-subendocardial delayed enhancement? So that's a very good question. It actually leads us down a different pathway because often this algorithm is to determine whether or not CAD is present. In that situation, if we find that we've delayed enhancements in a different pattern than anticipated for myocardial infarction, then this could be due to any number of other reasons due to delayed enhancements. It could be due to infiltrative disease, myocarditis, sarcoidosis, so pretty much a slew of other abnormalities. And I believe Dr. Shah is going to give a subsequent talk talking about delayed enhancement in more detail in one of the multimodality imaging presentations. And I hope that answers your question. Okay. Okay. So I'm going to take you through a couple cases that will hopefully get you used to using this algorithm. And looks like it logged me out. Give me a second. Okay, so we start off with our studies on top just to guide you, and the next row are our stress images for the relative same locations, and down below are the rest, and further down is our delayed enhancements. So starting with the algorithm, we start off with the delayed enhancements first, and on the delayed enhancements, you guys can see this well, I hope. So no scar. So that means we have to go to the next step of our algorithm, and that's to look at the stress perfusion. So let's do that. And do you guys see anything on this? Okay, so nothing on stress. So therefore, we've went through 2 parts of the algorithm. No delayed enhancement, no stress perfusion abnormalities. So this is a patient with a normal stress. Although in this case, I think it's more of a projection issue. Let me double check this. Yeah. Yeah, it doesn't project well, but there is an apical perfusion abnormality. Yeah. Okay. But this is a corresponding angiogram, and there's a suspicious lesion up here, but it's not the most obvious possible diag. Okay. Okay. This is a second case. And again, let's go through our algorithm. By our algorithm, we should start off with our delayed enhancement. And what do you notice right away? Yes, so there's a scar in what looks like an LED distribution. And that can be seen quite clearly on the short axis and on the long axis as well. But we shouldn't stop there. This is a good case where if you look in this particular territory, you get a similar pattern distribution here. And so thankfully here, the perfusion abnormality is matched with our delayed enhancement. Often we get patients that are sent with known prior MI, with known myocardial infarct, and then we're left being asked if there's additional ischemia on top of that. So we know to actually go through and answer that. We actually had a pretty good case of that yesterday in a patient with cabbage and multivessel disease. So the outside coronary angio confirmed that they were occluded LAD with collaterals, and there was actually an OM2 50 to 60% of bifurcation stenosis as well. And then this is a patient with quote-unquote resting ischemia. Let me blow this up. And in this case, this is the delayed enhancement over here. And not the most convincing in terms of scar, yes? Whereas a perfusion abnormality, and this is, unfortunately, this is very zoomed in. There's a hint of perfusion abnormality that looks more prominent in the infraseptal inferior walls. And I know this is very zoomed out, so please bear with me. But then we also see the same on the resting images too. So this is a potential match defect, which is likely an artifact in this case. Of course, again, there's a caveat that if you image too soon after stressing the patient, that you can still have persistent perfusion defects afterwards. So let me take you through some other actual cases. So we have a 54-year-old male. He's been having dyspnea on exertion for about 6 months, no classical angina. Treadmill test was equivocal because he only went for 3 minutes and had it terminated because of dyspnea and fatigue. And he got referred for a chemical stress CMR. I think your eyes are already gravitating to stress, but let's go by our algorithm. And delayed enhancement, what do you guys see? You're saying maybe something here? Maybe. Okay. Now, what do you think of the stress? There's quite a bit of perfusion abnormality in the anterior and septal walls, and it's very clear on the apicals, yes, and mid segments. Okay. And how does it compare with rest? Still there, goes away? Goes away. Okay. So this patient has maybe a subendocardial MI in the anterior wall, but a definite perfusion abnormality in the LAD distribution as well. And this is what his coronary angiogram actually showed. Here's a second case. We have a 76-year-old woman with diabetes, hypertension, hyperlipidemia, and moderate aortic stenosis who presents with chest pain, chest tightness, and dyspnea. She had a nuclear study 1 year ago, and that was read as negative. And Man, you gave me this case last year. So going by our algorithm, we start off the CNAs, any wall motion abnormalities? No big wall motion there. How about delayed enhancement? Not the most convincing, yes. Okay. Let me see if I can get this to... And how about the stress? Let's wait for it to cycle back. Maybe. Not the most convincing, huh? Okay.
What about, well, being biased, what about the inferior? Or is that an artifact in the rest images?
You're talking about down here?
Is that
Yeah, maybe. Okay. Here's a coronary angiogram. And the only thing that really shows up is this proximal and mid lesion here. It's kind of suspicious, and I don't know if I can slow that down for you. No, it's actually. But shown here is multiple significant lesions along the RCA, and I guess that's why Man was trying to draw attention to that. She ended up getting 4 stents to her mid RCA. Here's another case: a 61-year-old male with 4-vessel CABG, PAD, and diabetes, who comes in with worsening chest pain. Left heart cath showed severe left main stenosis, an occluded RCA, left circ, and LAD. The lima was patent, and the SVGs were occluded. And already you can see on the wall motion, there's already something suspicious on the lateral wall and inferior lateral, I should say. As you can see, there's very clear subendocardial MI on the delayed enhancements. This is using a sequence that actually makes where they actually lost a little contrast in the blood pool, so we lost a little contrast there, but it actually worked to our advantage. But the thing you'll appreciate is, even though there's infarct in here, there's actually more ischemia. There's more ischemia actually going up into the anterior wall as well. See that? Okay, so that's enough of the cases. Of course, there have been other trials that have been conducted that have established further sensitivity and specificity of this compared to angiogram, and also comparing it to other imaging modalities. CMARC actually had a part 1 and part 2. So when CMARC 1 came out, I gave a journal club at my fellowship for this, showing the sensitivity and specificity of this compared to angiogram, not angiogram, using angiogram as a gold standard. And we found that it was pretty good. You actually had sensitivity and specificity of CMR for detecting significant lesions in the 80s. Okay. This is the ROC curves showing CMR compared to SPECT in the same patient populations. And you can actually see the C statistic was a bit better for CMR compared to SPECT, looking for significant lesions. Greater than 70% up in panel A, greater than 50% in panel B. And this is for single vessel lesions versus 2 to 3 vessel lesions, ROC curves. CMARC 2 also occurred, and this was also looking at a strategy of how to manage patients presenting with chest pain, and they actually compared those. They actually did it on 1 to 2 to 2 ratio, where they looked at patients getting conservative management with using the NICE guidelines versus myocardial perfusion stress testing versus cardiac MRI. And again, they found that in terms of comparability between CMR and SPECT, they were pretty similar in terms of false positives, false and negative tests, etc. Okay. But most importantly, they actually reduced unnecessary angiograms compared to conservative management, as you can see in the top column, top row. Okay. And in terms of what about using it for prognosis, because we use nuclear studies for cardiac risk stratifications for pre-op. Data are still accumulating. Unfortunately, we don't have long follow-up data yet, although many groups are beginning to try to do this. So unfortunately, in the appropriate use criteria, cardiac CMR hasn't yet been put forward as for cardiac risk stratification for pre-op evaluation. So long story short, don't use it for that. It's simply because we don't have enough data behind that yet, although people are still using it. But overall, in terms of appropriate use, you can see stress CMR actually made it in terms of being considered an appropriate modality here for those who have intermediate pretest probability of CAD and high pretest probability of CAD as well with uninterpretable ECGs. Last but not least, what about HCM patients? And this is near and dear to our one of our attendings. Dr. Naga does a lot of research work with this, because there's a theory that that these patients have not necessarily coronary disease, but microvascular obstruction. We're accumulating data on that. Dr. Malafji is doing work with Dr. Naga, and hopefully we'll have a little better answer on that. But we're looking forward to seeing what that shows. Either way, it's been put forward that stress CMR might be a possibility for not only looking at the morphology of patients with hypertrophic cardiomyopathy, but also adding to the perfusion data. But again, we're hoping to hear more about that. Okay. And this is just a classic case that we get referred from Dr. Naga and company for such a purpose. And what this will hopefully show is the classic subendocardial ischemia that we see with these patients. So just to convince you, we see the typical RV insertion site scar, a very mild form of it in this case for this HCM patient, but not the most convincing lacy, patchy scar that we often see with these patients too. And then on the stress, you can actually see that there's a perfusion abnormality that's all around the subendocardium, although you get a little more localization on the apical views as well. Okay. And this reverses in rest. Okay. But to summarize, pharmacological stress CMRs become an established method for CAD detection and risk prognostication. It may have a role in detecting microvascular obstruction, ischemia in HCM patients. Exercise stress testing in CMR is possible, and people are looking at that. Hopefully, we can bring that to our center, but that's ongoing discussions with the heart failure group in terms of research as well. Okay. Well, with that, I'd like to open up the floor for any questions. Yes, Alpana.
For the match defects, so if you have a match defect but you have abnormal wall motion, can you just assume that there's severe resting ischemia in that case?
So the question is, if you have a wall motion abnormality in a region that is matched, the answer is it depends. Like I said, if by technical issues you image too soon after your stress, now let me take a step back. If there's no delayed enhancement and it's matched, there is the possibility that this could be a stunned myocardium. This could be myocardium that got stressed and is simply not moving. But if in this situation, if there is coronary disease, if there's significant lesion, you should ideally see reversibility of it. You know. Yes, Peter.
This is more of a basic question. How long is the breath hold for these CMR? Just because we,
how long is the breath hold for CMR?
Consults, we get CMRs, but I know they have to hold their breath, but I don't know how long they have to hold their breath.
So for the regular parts like the cines and delayed enhancements, the average delayed enhancements, the single shots, they don't need to do breath holds. Usually the techs know to try to optimize it between 5 to 10 seconds. Sometimes our phase contrast flows may go up to 10, 15 seconds, but we try to avoid that. The perfusion, we give them the instructions to try to hold out as long as possible, but if they tire out, they can breathe, but try to shallow breathe because we're trying to acquire about 100 cardiac cycles or so.
In that last case, with the HCM case, how do you differentiate, or can you differentiate like microvascular dysfunction versus epicardial coronary stenosis in CMR?
So the question was whether or not we can differentiate true epicardial stenoses versus a microvascular ischemia in the HCM patients. The issue is that's difficult. If it localizes in a coronary territory, we become a bit more suspicious for coronary disease. But if we see it at diffuse subendocardial, then it's hard to say because you're facing the potential issue of balanced ischemia as well. But then again, we would see the perfusion abnormality regardless. Okay.
Thank you.
Thanks, Dr. Yang. Great talk. Just question out of curiosity, where do you see the role of stress CMR in terms of triaging patients presenting to the emergency rooms with chest pain? Because there's like data about that. I don't know if it's just more in use in Europe versus the States, but is that something that you think will be used more in the future?
Do I potentially see stress CMR being used in the emergency room setting? That's an excellent question. The issue with CMR is not every center has it available. And not to mention, you would have to have properly trained technologists and attend physicians who would know how to interpret it well. In terms of throughput, sadly, in terms of the length of the study, it's quite a bit longer compared to, say, a cardiac CT. Mm-hmm. So there are some limitations in that regard.
Thanks.
Any other questions? All right, thank you so much. Thank you for your attention.